Then in 2015, antifibrotics came to the US. It was great. We're all waiting for them. They came, we started patients on them. The very first one to market was Pirfenidone. It is a pleiotropic antifibrotic agent. It goes after that TGF-β that I showed you kind of circulating there, and TNF-α, and it inhibits the fibroblast proliferation and collagen synthesis that's happening in that interstitium. It got approved for IPF and IPF only. They did not go back for any other trials. And you start at 267 milligrams 3 times a day. You go to 2 tabs 3 times a day. You go to 3 tabs 3 times a day. And then you can transfer them over to the 801 milligram tablet, which is, it looks like an augmentin pill. I mean, it's really big. 3 times a day. These patients have a lot of GI side effects. The adverse effects listed here is the photosensitivity, like getting sunburned in the car, nausea, vomiting, anorexia, and dyspepsia, and dizziness. Crippling fatigue was also something that was often mentioned post-analysis. A lot of patients had this just crippling fatigue. They couldn't get out of bed. That was seen with Pirfenidone as well. GI side effects are very difficult with these antifibrotic therapies. It says with food 3 times a day. It should say with protein 3 times a day, because not all foods get along with these patients. Protein does seem to help. Something I learned from Ms. Corey Fratelli, who's going to be talking to you guys later, is sandwiching protein. So eating some protein, take your antifibrotic, eat some more protein. So let's kind of surround that pill with as much protein as possible. And I've had some great success thanks to Corey with that one. This is the capacity trial, one of the trials that did help get this therapy approved by the FDA. It was a 72-week trial, which is a little longer than what we would normally see. A lot of our pulmonary trials are like 52 weeks, 24 to 52 weeks. So it was nice to have a 72-week trial, and did show benefit in controlling progression-free survival in these patients. The ASCEND trial was another pivotal trial for Pirfenidone to get it to market, showing improvement in decrease of their functional forced vital capacity and or death in these patients. And the patients who were getting the therapeutic arm did better than the patients who were getting placebo plus whatever their background therapy was. Then came nintedanib, and it is a tyrosine kinase inhibitor targeting therapy, also antifibrotic is what we kind of group it as. It goes after VEGF, it goes after FGF and PDGF for these patients. So it does work different than Pirfenidone does, but still kind of clumped into the antifibrotic family. It initially had its approval for IPF, went back and got approval for progressive fibrotic disease as well. And in their trials, they did include a lot of patients with connective tissue related diseases, which was very great for us to see because we had so many patients that were like, not all of our patients are IPF. You know, we'd love to start our other fibrotic patients on these therapies. It's 150 twice a day, which is nice. So it's not 3 times a day. So they have 100 and 150 milligram dose. Same types of GI side effects in these patients. Decreased appetite. There was a little bit of a signal for bleeding in the trial as well. And so sometimes we have discussion about stopping therapy before surgery or not. For the most part, the consensus, most people are not stopping these patients. We're not having like diffuse bleeding issues, but just something that patients might come across in their reading to talk to them about. INPULSIS was one of the trials, one of the 2 trials that looked at these patients. They had to have IPF for at least 5 years coming into the trial. Their FVC had to be greater than 50%, and 80 is considered normal, 80 or above of what's predicted for that patient. Their DLCO was between 30 and 10%, which is pretty severe. And then again, normal is 80 in that range. And then these patients were on concomitant prednisone. Less than or equal to 15 milligrams a day was allowed if they were stable. Coming in, a lot of the patients were not on steroids, but some of them were because, again, we had nothing better to offer them, at the time, a lot of the time. Secondary outcome for this was looking at time to first acute exacerbation. So they were able to show that they were able to slow the rate of decline in their FVC in the treatment arm versus the placebo arm. They were able to reduce also time to first exacerbation in comparison to the placebo group. And they had INPULSIS 1 and INPULSIS 2 trials, and they did not find a difference in those cohorts. So it was reproducible. All right, INBUILD was another trial. It was a phase 3 randomized controlled trial looking at nintedanib compared to placebo. They had about 663 patients in there. They looked at progression of fibrosis on their high-resolution CT imaging, which, by the way, if you're going to order CT, it better be high-res. Okay, just saying. You're going to make Palm cranky if you send them over with like a chest x-ray. Like, we'll take it and we'll order the high-res. But if you're going to order a CT scan, make it worth the while. Do a high-res CT. So they looked at these patients that had non-IPF diagnosis that were enrolled in this trial. And this is the breakdown of who was in the trial that did not have IPF. So this was a great study for us to kind of see the patients that we were hoping to start treating with antifibrotic therapies that did not fall in that IPF arm. They did show significant reduction in decline of FVC in these patients. There was no difference in the patient's symptom or acute exacerbations or mortality. And then there was increased rates of GI side effects in the patients and transaminase. So this is where we start watching LFTs, which a lot of times you guys are looking at with some of their therapies anyway. And then there was some similar efficacy between Pirfenidone and the nintedanib group as well. And so these patients' decision of, well, not the patient's decision, but the provider's decision of which antifibrotic do we start on the patient, kind of that door opened a little wider when we said, well, this therapy is actually approved for everything else that is progressive and fibrotic outside of IPF. So we can use it for IPF, we can use it for fibrotic diseases that appear progressive that are not IPF, versus Pirfenidone still only is technically approved for IPF.